Okay, it's just now 8:30. So, but we will give it another minute or so to clear the waiting room.
Yeah, I still don't see anybody in here besides Cresta.
I don't either, and we have cleared the waiting room. So if you would like to go ahead and start, we have been giving some friendly reminders to all the TACs. All voting members must be on camera while voting. And also, we've been having some issues with the court reporter being able to capture some of the conversation if people are talking over top of each other. So we're just trying to remind each other or everyone to try to use the hand raise button, to the best of our ability. And so we're just reminding everybody of those few things. And the waiting room is clear, Dale. So if you would like to go ahead and start. I only still have 2 members on, but if you get more members, I can always let you know.
Okay, I appreciate it. Good morning, everyone, and thank you for joining the Therapy TAC meeting. We only have 2 members on at this current time. It's myself, Dale Lynn, and Crystal Wilson. Hopefully, I know that Emily is going to be out. She did give me a notice of that.
I think Linda is joining. It just says Linda on the name. So as soon as they get logged in, we'll see if that is.
Okay, yeah, it usually does just show her first name.
Okay, I think she's logged in. Linda, are you there? She is. Yep, there you go.
Perfect. Thanks, Linda, for joining. So we do have a quorum of 3 out of the 5 members we currently have. So I'd like to first of all start off with reviewing the March 14th minutes. Krista and Linda, have you had a chance to review those?
Yeah, everything looks good on my end.
Good.
Yeah, I reviewed those minutes myself, and I didn't attend that meeting, but I would say that we can approve those.
Yeah, I'll make a motion to approve.
Linda, did you get a chance, Linda, to review those minutes?
Had to unmute. I'll second.
Okay, thanks. Old business is first item is to follow up from the Department of Medicaid Services. What are the department's study findings on increasing the PTOT speech fee schedule? And I met with Justin Deeringer Friday, and we had conversation about that. And I believe the the department has a July 15th deadline to complete their study, and they have studied the fee schedule plus the First Steps fee schedule. So the fee for service fee schedule and the First Steps fee schedule, and the governor has given Medicaid a directive to have that completed by July 15th. So that's encouraging. Is Justin on the call today?
Yes, sir, I'm here. Can you hear me?
Yeah. How are you, Justin? It was nice to meet you last week.
Yes, sir. Thank you. Very nice to meet you too. Yep, as we discussed, we did an internal study initially, reviewing the Medicare rates, looking at all the other states that are surrounding Kentucky, looking at the different types of therapy that's given by different providers. We looked at waiver, we looked at EPSDT, we looked at all the other therapy provider types. So we grouped all those findings in what we are currently paying, what our rates are versus what all those other surrounding states pay. And then we looked at all three different providers that provide therapy or the provider type they were enrolled in and the rates that they were being paid. So we had that study complete, and then we decided to do a little more in-depth study, look at other states that have similar demographics to Kentucky, look at some private insurance rates and some other factors. So we actually contracted a contractor to do that in more in-depth study. And as soon as that one's done, we'll kind of combine those two, go through the data and information, do some fiscal analysis, and see exactly what we can do and what needs to be done. So that rate study is not completed yet, and so that's kind of where we're at with that one.
Thank you, Justin. It's looks like you made a lot of progress on that. Appreciate it. Any other comments around that topic? The next thing on the old business on the agenda is to follow up on Medicaid's requiring physician signatures on a plan of care before approving prior authorizations. As we discussed that also, Justin, last week, and I was wondering what the progress is on getting a response. I understand that the signatures on the plan of care was from a interpretation of in collaboration with a physician, and just wondering what the policy is regarding that.
Yes, sir. So that was the interpretation of that part of the regulation and at the time. And so what we've done is we've created a decision memo. We did some research looking at, again, some language from some other states. We looked at some different insurance company procedures throughout the United States as well. We compiled that into a decision memo and have just sent that up to the commissioner's office for review. So as soon as we get a decision back from that, we will let you all know what that decision is.
Okay, well, I'll follow up on that.
Yes,
Thank
sir.
you. The third thing on old business is credentialing concerns, streamlining credentialing process with MCOs. I believe it was Stewart maybe that talked about this at the last meeting regarding using Verisay, Verisis. I'm not sure how to pronounce that. I apologize.
Yeah, it's Stuart on with WellCare. And so luckily there was another TAC that had an update on this yesterday. The Kentucky Hospital Association and Verisis, and they somebody from the KHA who spoke and mentioned that there are 3 MCOs, which is WellCare, Aetna, and Molina, who they will go fully functional with in July. This is what they announced. And they've hired somebody else at KHA with the goal of getting the other 3 MCOs on board by the end of the year, but it's not live yet. But for those 3, they indicated, so I mean, we'll see that in July it'll begin for those 3. And by the end of the year, they'll have all on board and we'll see. But that's the update. It was yesterday. It's actually yesterday that they gave that update.
Well, that's great to hear. So will a person that wants a credential, would they just go to Verices? Or would they go to the MCO and then be directed to Verices?
Yeah, my understanding, it'll all be with Veris. It's a credentialing alliance is what it's called.
Mhm.
It's KHA and Verisis. And that I think the MCO site would direct you there. If you started with the MCO, you'd get routed to the alliance. And so that it'll all be done through the alliance is my understanding.
Yeah, that sounds like it's going to really help to streamline it, because I understand Verisis is a pretty good credentialing agent to work with.
And there was legislation you may or may not be aware of during this past session. Because the goal was for all MCOs, or the hope was that all MCOs would sign. And it basically says if all the MCOs don't sign with the alliance by the end of the year, the Department of Medicaid Services would have to issue an RFP for a singling credentialing organization, which is kind of where we started about 4 or 5 years ago, I think.
Mhm.
So there's legislative pressure as well.
Right. Well, I appreciate your input on that.
Yeah, you're welcome.
Anyone else have anything on that topic?
Yes, this is Dr. Tom James with Passport Health Plan by Molina.
Mhm.
Just to clarify with Stuart, because he and I used to work together. Each health plan under MCQA still has to have its own credentials committee. But what we'll do is be gathering all the information. And I verified yesterday that we're going to be all set with Verisis.
That is good news.
Yep.
Thank you for your input. The next thing on the old business is that Anthem is not paying for CPT code 96122 developmental testing. There was discussion in the last meeting about this, but I think it may have been resolved. Is that correct? Is anyone from Anthem on the call that can address that?
With Anthem. And yes, we did research. We researched our claims going back to dates of service from
Therapy TAC.
and we did not find any issues with payment for this code. So if there is anyone that has a particular issue with payment somehow, please don't hesitate to reach out to your provider rep or provide us the particular issue. We're happy to look into it, but in our research, we can find no issues with this code.
All righty. Thank you very much. The next thing on the agenda is actually we cover that on the second part of old business. So the last thing on the old business agenda is follow up with the department permitting Humana MCO Evercore to create their own medical necessity criteria.
Good morning. This is Kathy Kaufman from Humana. Can you hear me?
Sure can. Thank you.
Okay, thank you. Yes, in follow-up to this, after the concerns were raised, primarily by Marshall Pediatric on our last meeting, we did follow up. It was confirmed on that meeting that Evercore was able to submit their clinical guidelines to the department, which was done prior to our go live, and that was approved. And we did, Humana and Evercore did provide educational training prior 2 seminars prior to and 1 after our go live, utilizing Evacor to complete our therapy authorization request. We did also provide a link to the department afterwards to Evacor's website, which they can access directly the clinical guidelines. And then also the PowerPoint that was provided to during the trainings is published on our provider website. And we also provided the link for that. Our provider relations representative, Pam Trujillo, did set up a meeting, and we met with Pam Marshall and her team, including the Evacor team, on March 22nd. And at that time, we did address their concerns and reviewed any questions they had on individual authorization denials. We left, the conclusion is that they were going to review the information that we had provided to them and would request another meeting if necessary, but we have heard no further concerns.
So my question would be that I was under the impression that it was interqual minimum were the 2 criteria that need to be met for medical necessity. And can somebody from Medicaid respond on why they would allow an MCO to create their own criteria?
Just to clarify, Dale, Humana did not create the clinical criteria. This is Evacor's proprietary clinical criteria, and it was submitted, as I said, to the department. Angie Parker did confirm on the last call that MCOs are able to submit additional clinical criteria for review and approval, and this was completed before we went live.
So I guess my question then would be to Angie, if she's on the call, why would the department allow an MCO to create their own criteria? Or not an MCO, or Evercore rather? Is there something in the regulations that maybe I'm missing, or anybody else on this call is missing, that would allow them to create their own medical necessity criteria?
I don't see Angie on the call, but I can take that back and follow up with you.
Okay, thank you.
This is James with DMS. I'll go ahead and take that question. There is some latitude in the current regulation that MCOs have to add additional criteria beyond the existing regulation. So what Kathy was referring to is that they have a contract with Evacor to administer that. So Dale, I can definitely get that regulation to you and your team so you guys can follow up on that.
Yeah, that'd be great, James. If you can send that criteria to the Therapy TAC members so we can review that in the regulations and take that up.
No problem. No problem.
Thank you. Dr.
Good
Cantor?
morning. Yes, good morning. Thank you. I'm Dr. Cantor with United Healthcare, the CMO, and if I've been following this conversation correctly and my understanding of the contract, MCOs are allowed to we are allowed to provide utilization management, and if interqual does not speak to the specific subject matter at hand, we are allowed to make clinical guidelines in all conditions that follow the standards of care. Those clinical guidelines at United Healthcare are overseen by not just United Healthcare subject matter experts, but they are overseen by various experts professional societies, non-UHC associates, so they are not driven, they're not completely written and overseen by associates at UHC. So we're allowed to write policies, especially when interqual may be silent. And then those policies are submitted to DMS for their approval. And any third party like Evacor, we also use Evacor, we submit those policies on a monthly cadence, because each policy gets reviewed annually for any medical updates, and they're submitted to a specific state SharePoint site. So if I followed correctly, and having worked at other MCOs, that's typically the process. MCOs are allowed to adjudicate and write. They're allowed to adjudicate based on medical policies that are created by the medical policy committees at our MCO. I hope that made sense.
Yeah, it does, Dr. Cantor. And I look forward to reading the regulation around that. Thank you.
Sure. It's in our contract, and I could send you that section on utilization management if you would like.
I'd appreciate that, Dr. Cantor, if you would. Thank you.
Absolutely.
Pam, I think you have your hand up now. Is that correct?
Yes, I do. So the question we didn't get answered, Dale, is what is it in the, Milliman or interqual criteria that was not met? What was it that wasn't met that forced Humana MCO to use Evacor's additional criteria? That's the question that has not been met when we've, asked that over and over. We're just trying to understand, how did it come to this? Because the regulation was written so there would be a uniform kind of standard, and that, insurance companies couldn't just on a whim make up different criteria. So we just want that question answered. What was it that was not met that allowed for this extra criteria?
So this is Kathy Kaufman again. It's not that we had previously been reviewing our therapies prior to our contract with Evacor going live, utilizing MCG guidelines. But as everyone is familiar with and has already been stated, in some instances, interqual and MCG do not provide, detail for some, request or conditions. When we entered into the contract with Evacor, they did share their clinical guidelines that they have created, utilizing best practices and information, the most current information. These clinical guidelines were submitted to the department prior to our go live, and they did approve those for use in our therapy request. So it really wasn't that, we felt like MCG was not appropriate for use. It's just that Evacor did have their much more specific clinical guidelines that were proprietary to their company that they have been using, and it was approved. And those guidelines are available, and there is a link on Evacor's website that they're able to be accessed. So if there is specific questions about that, then you can definitely review that. And again, Pam, if you have any questions specific on any authorization denials, we are happy to, do the research with Evacor and discuss those on another call.
Okay, I'm just wondering if there's a conflict here from between the regulation that the providers go by and the contract between the MCO and DMS. Because the language in the regulation says that if it is determined that a medical necessity criteria is not available or is not specifically addressed for a service or for a specific population, the contractor shall submit its proposal for medical necessity criteria for approval. So in our minds as the provider, that there has to be either not available or it's not specifically addressed. There has to be a reason that additional criteria is created. And that's the way we read it. We don't necessarily know the contract language between the MCO and DMS, but it's a conflicting, from a provider standpoint, this is conflicting. And that's what we're, as a group, as a whole, we're requesting that this be cleared up, because we're asking, what is the specific criteria that wasn't addressed that allowed for additional criteria to be developed or used? Even though it says, the department may require the use of other criteria, and it creates or identifies for services or population not otherwise covered by the named criteria in this section. That's the language in the reg. So we're requesting that someone look at the regulation that we follow and see if there is conflicting information here.
Hi, this is Justin Derringer. I appreciate the conversation, and I know I understand the issue. So let me take this back. Again, we have a current decision memo on signatures, verifying doctor cooperation. Let me put this in that same format, do some research and submit that. And so we can get you all a definitive answer from the Department for Medicaid Services, if that would be okay.
Yes, that would be okay.
Okay.
Yeah, they'd be very, very helpful. Justin, appreciate it. Okay, on to new business. A Kentucky provider brought up a concern regarding a patient who is insured with an MCO and is being evaluated for disability. The MCO realized that this person was being evaluated about 6 months or a year ago, beginning the evaluation process, and realized that when an individual is in the disability evaluation process, they default to traditional fee-for-service Medicaid. And so the MCO retroed back and to the beginning date of when this person was began their evaluation process, and recouped payments, and this person was defaulted to Kentucky Medicaid. So the problem with that is the MCOs have different criteria for prior authorizations than Kentucky Medicaid has. Kentucky Medicaid requires an authorization to be 90 days, not 91 or 89. They require the physician's signature to be on the plan of care within 30 days of the service. And the MCOs have different, more lenient requirements. Most or all of them, MCOs don't require a physician's signature on the plan of care, for one. So this is problematic whenever this provider went to Medicaid to get retro back their authorizations, which the wonderful thing about Medicaid is they will go back a year and retro off. But the criteria is so different that it is so problematic for a provider to be able to capture all that, those dates accurately. And I guess what the TAC is requesting is that Kentucky Medicaid just honor the authorizations that the MCO gave at that time, and then from that day forward, go by the Kentucky Medicaid's policies on prior authorizations. Does that all make sense?
Yes, sir. That absolutely makes sense. I understand, what you're asking at this time. However, I think in our administrative regulations and our policy and procedures, we have different criteria. So we would have to follow that unless we did a change, unless we made a change to that. And I think part of the last statement that we discussed, we can also discuss the possibility of making some sort of change in that circumstance. I'm not sure, usually if especially if it's an administrative regulation, once it's set until it's changed, and that could be up to a year-long process to get that changed. If it's something that's in policy, then we can review and make a change to that. But what we won't be able to do is to be able to do, I think what you're asking for here, the reason for that is if we have our criteria set in policy, if it's in regulation, our hands are tied until that regulation is changed. That's state law. If it's in policy, we can review that and make a change. But that has to be the policy for all cases that are brought to us. That has to be, the criteria has to be the same for all prior authorizations for traditional Medicaid. So it's not a big deal for us to look at that, reevaluate those policies and make changes to those policies. But it has to be the same for everybody all the time. So having said that, we do give MCOs a little leeway, some flexibility to be able to serve their members the best way they feel possible. So that makes the criteria a little different. As you said, it's allowed a lot of the MCOs to be more lenient with things like provider signatures and some of the other requirements that we have for fee-for-service traditional Medicaid. But because we allow them all to be different, we're not able to adjust to each one's own specific requirements for prior authorization. So if we were to do that, then we would have no real set criteria ourselves. I hope that makes sense, and I understand the dilemma that you all are having with that. I'm hoping that by looking at the signature requirement, we can ease some of that. But I think we won't be able to ease all of that due to making sure that we have an actual policy in place that sets criteria, and we can't really make that flexible for each MCO. I hope that makes sense.
Yeah, I understand, Justin, but the situation is, what's the provider do when they've provided a service for maybe up to a year, and they were never notified that by Kentucky Medicaid that this member prompted back to Kentucky Medicaid for their insurance. So, why doesn't Kentucky Medicaid notify the provider when that happens? Or do they not know themselves when that occurs? See, that's the real dilemma.
So without knowing the specifics, I don't know exactly what happened or when, but if you could, if you will email me the specifics after the meeting, because we do look back at on a case by case basis. If something happened that was our fault or that was out of the control of the provider and MCO, and it's something that we can go back and look at and fix, we do look at those. At least weekly, we get cases like similar, maybe not the same, but we get cases where things have happened. So if you can get with me after or somebody can after the meeting and send me some specifics, we can research that and see what we can do.
Sure, I'll be happy to get with you, Justin, and I'll contact that provider that notified me about this situation, and we'll both speak with you. But that's a real issue about the provider that had no idea that they got, their patient got defaulted back to Kentucky Medicaid, and they provide these services and aren't going to get paid for them. So,
Dale, can I add to this?
sure.
I speak. Okay. So our practice, I'm not sure if anyone
This
else.
is Pam Marshall, right?
Yes, Pam Marshall. We've had 4 cases from WellCare, and one of them dated back more than a year. And here's a couple problems that if you can investigate the provider screen, what the provider sees, because there's no date on the provider screen of when Medicaid changed that retro, because we check Medicaid often and verify Medicaid, all the time when a patient is coming in. So this was a retro situation of 4 patients. One goes back more than 13 months. So the regulation, what happens when we need a prior auth for that month that's beyond the year from the regulation. We need to get paid in this situation because we have screenshots of what we see, and this information was not available until more than a year. It retroed more than a year back. And this used to happen a lot in 2014, 2015 when we were new provider types, but it hasn't happened for many years. And I don't know if this was a fluke thing, but we can give you the 4 examples we had as a reference. And I don't know if anyone else in the state is experiencing this same thing. But, the MCOs are quick to recoup that money. And then the provider is sitting, waiting to get prior auths to be able to submit those claims. And especially many of these children are receiving multiple services. So it's hundreds of claims. And it's a big administrative burden when this happens as well. So any help to streamline this process and to help us, the provider, understand, are more of these coming? Like, what triggered this? And do we expect there to be more of them where this was missed? Because our practice alone gets probably 10, 15 requests a month for disability, submitting records for disability. So what is happening when those children are going through that disability determination? Should we expect and proactively expect them to flip to fee-for-service Medicaid? That's what we need to understand as providers. And I think there may need to be an additional column on the screen that shows when that retro was added to KEMIS. And I know if you're switching systems, is it in the new system? Does it show when Medicaid, when DMS personnel added that to the computer? Is there a date? Because people are going by different dates. When we're trying to submit a PA, they have a different date than what we have or what we see.
Yeah, that makes complete sense. And I know that used to be an issue, and I'm not sure why it's starting to pop up more, but
Thank you, Justin. We'll continue to communicate with you on that subject, and hopefully that we can get Kentucky Medicaid to have some flexibility on their prior authorizations, approvals under those circumstances. Is there any other discussion on this topic?
The only thing that I have is, this is Linda Durosset, but when you were talking about the retros and, one will retro and one won't retro, I just think that, maybe we can look at that, or maybe the MCOs could look at that and be more consistent with being able to retro a few things, or at least, a few days or anything like that. Because it seems to me that when we've talked through some of the meetings, that there's been errors maybe made by the MCOs that has had to, wait on payment or wait on, recoupment by the providers, although there's no leeway for the provider to make an error and have to retro. So I think that, it's kind of a two-way street, that if we're giving leniency to the MCOs to make an error and come back and pay us later, then there should be a little bit of a leeway on the provider's part to make an error or miss a deadline and go back and recoup that. Because I don't think that we're trying to cheat the system. We're trying to treat the children, I said, and we're trying to do the best we can. And there's some things that fall through the cracks. And I think there should be a little bit of leniency there. If we're, doing it back and forth, I think that needs to be addressed. I don't know if anybody agrees with me.
Yeah, I certainly agree with you, Linda. I've had to request some retro auths, and some of the MCOs are fairly lenient on that, and some are not. Any other discussion on that? If not, we'll move to the last item that I have on that the TAC has on new business. And a Kentucky provider reported that United Healthcare has removed the CPT code 97533, which is Sensory Integrative Techniques, as a covered code. And I was wondering if the UHC.
Sure. Good morning again. Yes.
Thank
Hi,
you.
Dale. This is Dr. Cantor with United Healthcare.
Yeah.
I appreciate the agenda being put forth. I think last week it gave us an opportunity to review this in advance. So I really do appreciate the notification with the agenda. Actually, 97533 has been removed from the prior auth. So it's not that it's not covered, it's that it doesn't require prior auth anymore. It's still a covered code and it's available. Just the administrative burden of the prior authorization part has been removed.
Okay, I understand. I saw in a provider letter, I guess it was, and it wasn't clear that's what it stated. It just said.
Yeah, I'm catching that now. I've got an email from the provider that was questioning this, and it does look like that when we wrote that, it wasn't clearly stated that the prior auth was removed. So I'm trying to figure out where that bulletin came from, and I'll work on that. But hopefully everyone on this call, all the providers, have that understanding that it's a covered code, no prior auth is needed.
All right, I appreciate that clarification. That's what kind of triggered this question was that.
Yeah.
Newsletter that it was removed from payment.
No, not at all.
Thank
The
you.
other way around, the other end of the spectrum.
Yeah, great. Glad to hear that.
Yes.
Are there any other issues from TAC members or the public on this call?
Hey,
I
Dale.
thought
I
I
have a-
saw Pam's hand up.
Pardon me?
I thought I saw Pam Marshall's hand
Oh,
up.
okay. I did not see that. Sorry.
Thank you.
Pam?
Yeah, I was just going to add to the 97533 and UHC issue is that it was on the prior auth end being viewed as it would be a non-covered code at first, and it was not listed as a covered code on the medical policy. So I think it appears it got straightened out, and it appears there is language that states Kentucky is the exception for that medical policy that says this code is not covered.
Gotcha.
Where might you be seeing that?
I can provide the reference to you, Dr. Cantor. I can
Thanks,
send
Pam.
it. Yeah.
Is that in our bulletin?
Yeah,
Or
it
is
came
that
out in the provider
provider
communication.
network?
Mm-hmm.
But is that the confusion that
Yes.
because it
yes.
wasn't listed as the codes that
No,
were
it actually was communicated to us as of June 1st. It would not be a covered code. Mm-hmm.
I have emails from just a couple weeks ago where our team said that they will no longer require auth or clinical review and it's covered. I'll forward that string back to you, Pam.
Okay.
But I'd like to see what you're seeing too.
Yeah, there might have been just some confusion about it, but I'll
Yeah.
send you what we had, all the different bulletins that came out.
Thank you.
Mm-hmm.
Thank you.
Yeah, Elizabeth, you had your hand up?
Yeah, I did. My name's Elizabeth Rodas. I'm faculty at the University of Kentucky. I'm also an occupational therapist. And I am joining on the public's behalf. I do a lot of research related to mental health and behavioral health. And we use a lot of different sensory techniques and things like that. I predominantly work with older adults and people with dementia. So I don't want to chime in so much as to new business number 2 related to United Healthcare's reimbursement with the sensory integrative techniques, as I do just want to speak out to the need for establishing occupational therapy as an approved behavioral health provider so that we can then expand some of our opportunities to provide some of these sensory techniques for neurological and behavioral regulation. I have a slew of research and evidence. We have $1 million NIH clinical trial that I'd love to kind of present and talk about. I'm going to have to go in just 2 minutes for another meeting, but I just wanted to introduce myself to the team and say that we are doing nationally funded work specifically related to sensory-based interventions and the opportunity and the need to coordinate in our state occupational therapy and the approval for behavioral health across the board. So thank you for letting me introduce myself, and I'm going to put my email in the chat, and I would love to continue the conversation if that's an opportunity. Thank you.
Yes. Thank you for your input, Elizabeth. Krista, you have a question?
Yeah, I hopefully just wanting to get some contact information because I have a few things, a few questions for someone with WellCare and a few questions for someone with Aetna. So if anybody, representatives from those 2 MCOs on this call, if you could put your email in the chat, I would really appreciate it. And then also Dr. Cantor, if you can put your email in the chat, because I have a feeling we might have some additional things pop up with that 97533 code. Thank you.
Any other concerns or issues that TAC member or public has?
Is there anybody on the call with Aetna?
Yes, this is Crystal Rausner.
Okay, great, Crystal. Thank you. Do you care to put your email in the chat for me?
Yeah, sure will.
Thank you.
So it doesn't look like we have any recommendations for the MAC. Do we, TAC members? So if not, our next therapy TAC meeting is Tuesday, July 11th at 8:30 Eastern time. And I look forward to seeing everyone then. Thank you everyone for attending.
Thank you, Dale.
Thank
Have a
you.
wonderful
Thank
Friday.
y'all. Everyone have a pleasant day.
Thanks,
Have a
Dale.
great afternoon.
Take care, everybody.